Physiology and Control of Blood Pressure. Who is presenting that?
So myself, sir. Good evening, sir.
Can you switch on your video for a minute and show your face and then proceed?
Actually, there is a power cut in my house, sir.
Oh God. Okay, right. So we don't have the opportunity of meeting you. Right. Go ahead.
Yes, sir. Good evening, sir. My topic is all about blood pressure. So, definition of blood pressure, it's a lateral pressure exerted by blood on arterial walls. Elevation of blood pressure more than normal is defined as hypertension. According to Joint National Committee 8, hypertension is defined as an high blood pressure more than or equal to 140 systolic and more than equal to 90 millimeters of mercury diastolic. So, categorization of blood pressure includes normal is less than 120/80 millimeters of mercury. Elevated is systolic 120 to 129 millimeters of mercury. Diastolic is less than 80 millimeters of mercury. Stage 1 hypertension is 130 to 139 systolic, 80 to 89 diastolic. Stage 2 hypertension is more than or equal to 140/99 millimeters of mercury. BP monitoring is mainly done by invasive and non-invasive method. The non-invasive method mainly includes use of sphygmomanometer and automated non-invasive BP monitoring. Invasive method is mainly indicated in hemodynamically unstable patients, patients with end organ damage, the patients undergoing major surgery with major blood loss or fluid loss. It gives beat to beat blood pressure variations. Coming to the types of hypertension, there are two types, essential or primary and secondary hypertension. The primary hypertension do not have any identifiable cause. However, there are some theories suggesting there would be increased systemic vascular resistance. Other factors may include obesity, increased insulin resistance, high alcohol intake or salt intake, aging, stress, etc. The secondary hypertension as an underlying condition for the increased blood pressure, which includes chronic kidney disease, coarctation of aorta, Cushing syndrome, any glucocorticoid excess, drug-induced pheochromocytoma, primary aldosteronism, mineralocorticoid excess, any renovascular hypertension, thyroid disorders like hyperthyroidism and sleep apnea syndrome. Coming to the regulatory response of blood pressure, it includes a short-term and a long-term response, which is mainly baroreceptors and renin angiotensin aldosterone system. Coming to baroreceptor reflex, there are two baroreceptors located in the major arteries, which include carotid body, which is present in the bifurcation of internal and external carotid artery, and another one is aortic body, which is located in the arch of aorta. Both receptors sense the stretching of the vessels, which is increased during the increase in blood pressure, which is collapses during decrease in blood pressure. Both these vessels send stretch sensations to the central nervous system through glossopharyngeal nerve as well as the vagus nerve. The center is located in the medulla and pons, and then when these receives the impulses from these stretch receptors, they get they activate the parasympathetic system, releasing parasympathetic system, decreasing the heart rate, and they also decrease the vasomotor tone in the blood vessels, resulting in decrease in blood pressure as well as decrease in heart rate for increased blood pressure. The vice versa happens in the reduced blood pressure. Coming to the pathophysiology effects of blood pressure on various systems, the first thing is it affects on heart. There would be increased systemic vascular resistance, which lead to the heart to pump more, leading to increased myocardial workload, resulting in myocardial hypertrophy. There would be increased wall tension and oxygen consumption. There would be increased myocardial oxygen demand. All these leads to endomyocardial fibrosis. These results in left ventricular hypertrophy, systolic diastolic dysfunction, heart failure, ischemic heart disease. The effects of blood pressure on brain includes there would be cerebral autoregulation, which ensures constant cerebral perfusion at a mean arterial pressure of 50 to 150 millimeters of mercury. In chronic hypertensive patient, the autoregulatory curve shifts to the right. So whenever there is a slight BP changes, the cerebral perfusion is greatly affected. So they may result in conditions like stroke, TIA, dementia or loss of vision. The blood pressure effects on kidney is mainly in chronic hypertensive patient. It may lead to glomerular sclerosis, which is scarring of glomeruli. So the renal perfusion will be decreased, and it in turn increases the renin angiotensin aldosterone system. So there will be increased release of renin. So vasoconstriction will be acting. So increased sodium and water resorption will be done. So it again results in chronic hypertension. It's like a cycle. It keep on goes. So all these things results in chronic kidney disease. The GFR would be reduced to less than 60 ml per minute. And they may also result in albuminuria, that is more than 300 mg per dl of proteins in the urine. On vascular system, it results in increased arterial stiffness. There would be increased systemic vascular resistance, coronary calcification, endothelial dysfunction and all. So these results in peripheral arterial disease, carotid arterial disease, aortic aneurysm, and there would be wide pulse pressure change. Coming to the anesthetic concerns, in preoperative clinic, when we first encounter a patient with increased BP, we have to consider white coat hypertension. Uh, it may be mainly due to patients' anxiety towards the clinical professionals. So we may consider ambulatory BP as well as home reading BP in these patients. Proper technique of measuring should be ensured. We should take an average of 2 to 3 readings within 15 to 30 minutes gap, and we have to ensure the patient is calm and quiet also. The history taking in a hypertension, we have to get information regarding whether the patient is previously diagnosed with hypertension or not. So we need to know about how it was diagnosed, what was the initial BP when it was diagnosed, what was the medication prescribed, what was the response to the treatment, any follow-up or monitoring has been done, any organ damage has been reported like angina, any stroke, CKD, or any hospital admission for any emergency or accelerated hypertension. All these details we should be collecting in the pre-op clinic itself. And we have to also collect information regarding lifestyle and risk factors and all, about the diet, alcohol intake, smoking, any sedentary lifestyles, diabetes, etc. The important thing is also about the drug history, whether the patient is taking any drugs like cocaine, steroids, OCPs, SNRAs, caffeine, etc. Coming to the general physical examination, we have to classify the patient based on the BMI, whether the patient is obese or not. And in physical examination, we have to find out either the patient is on any cardiac failure, looking for any pedal edema and all. In systemic examination, we have to auscultate for any abnormal heart sounds, any wheeze, creps, etc. And we also have to assess the carotid artery for any bruising. And we can also follow the patient for fundoscopic examination to rule out any retinopathy, hemorrhage, exudate, anything. Coming to the laboratory investigations, we may ask them to follow it up with serum electrolytes, renal function test, FBS, fasting lipid profile, TFT, and urine analysis. Other investigations, we follow it up like ECG for any cardiovascular changes, echo for elderly and other comorbs included patients, chest x-ray, and venous Doppler if we are suspecting for any renal artery stenosis kind of patients in young patients. Dexamethasone suppression for steroid overuse for those kind of patients. Coming to the management, we have to follow, we should not start the patient with a drug directly. We have to ensure the patient is undergoing any lifestyle modification. Like we have to ask them to reduce their weight. We have to ask them to reduce their salt intake, like 4 to 6 gram per day. And we have to give information about DASH diet, that is a diet rich in fruits and decreased saturated and total fat, rich in potassium, calcium, magnesium and all. And also about the moderation of alcohol consumption. If the lifestyle modification fails and the patient is still having the elevated blood pressure, we can start with the drugs. Coming to starting drugs, we may divide the patient on the age. Like if the patient is less than 55 years and the patient is diabetic, we can start with ACE inhibitors or A or B. If the blood pressure is not reduced, we can start with calcium channel blockers or thiazide groups. So if the patient age is more than 55 years, we start with calcium channel blockers, and then we can add with ACE, ARBs or thiazides. If the patient is taking three medications like ACE, ARB or calcium channel blockers or thiazide groups, still the blood pressure is still high, he may be a resistant hypertensive also. We can start with the fourth drug based on the potassium levels. Either beta blockers can be started or spironolactone can be started. And we have to maintain the target blood pressure should be less than 140/90. If the BP is still high, we may need an specialist opinion also regarding this. And coming to managing the preoperative antihypertensive treatment, ACE or ARB should be withheld 24 hours before the surgery, since the patient may land up in rebound hypotension. And coming to beta blockers, if the patient is on beta blockers already, or he's started beta blockers at least 10 to 15 days before the surgery, he can continue. And POISE guidelines suggest that we should not start or abruptly stop the beta blockers, since it may increase in the mortality as well as stroke in the perioperative period. And other kinds of hypertensive should be continued till the day of surgery. Coming to the blood pressure target for surgery, the safe blood pressure for surgery is less than 180 millimeters of mercury for systolic and diastolic less than 110 millimeters of mercury. Above 180, 120 millimeters of mercury, there would be risk for end organ damage. Hence, risk and benefit for the surgery should be evaluated and the patient can be taken up for the surgery. Coming to the problems for anesthetizing a patient with uncontrolled hypertension, these patients may land up in cardiac ischemic events, arrhythmia, autoregulation is already shifted to the right. So, cerebrovascular events can happen. Exaggerated response to intubation and extubation would be that there would be presence of diastolic dysfunction also. For these patients, conduction of anesthesia includes we have to start with pre-medications, like we need to reduce the anxiety of the patients by giving alprazolam, like benzodiazepine the day before the night before the day of surgery, like oral 0.25 to 0.5 mg in the night before the day of surgery, or short acting benzodiazepine like midazolam before induction, or alpha 2 agonists like dexmedetomidine, clonidine can be given. These have a better hemodynamic stability, anxiolysis, and sedation. Coming to the induction, the use of opioids should be liberal. It is mainly for attenuating the laryngoscopy and intubation response. Etomidate is more cardiac stable than propofol or thiopentol. It's better to avoid ketamine since that would be increased heart rate and blood pressure. We have to perform a smooth, gentle, fast scopy in these patients that we could take less than 30 seconds. And we can also give intravenous preservative-free lignocaine 1.5 milligram per kg 90 seconds before the laryngoscopy. And we can also give esmolol before intubation. And coming to the maintenance of anesthesia, we have to maintain adequate depth of anesthesia, since awareness and all may cause an increase in heart rate and blood pressure. So we have to maintain proper adequate depth of anesthesia, proper analgesia using opioid use, and we can advise local infiltration before incision, and we have to maintain proper fluid management. We should not restrict fluid to these patients and all. And we should prevent hypovolemia, hypothermia, hypoxia, and hypercarbia in these patients. Coming to the extubation, we should avoid coughing in these patients, since the blood pressure can rise very high. We need to give opioids during recovery, and we can ensure giving lignocaine again with 1 to 1.5 milligram per kg for relieving the pain of tube in the patient. And we can extubate these patients in deeper plane if the airway reflexes has come and the patient is can be extubated in deep. Coming to the post-op hypertension, The main cause for the post-op hypertension would be pain, intolerance to ET tube or full bladder, or the patient would have been in ACE or ARB the day before the surgery. So these things would have caused increase in blood pressure. We need to treat the etiology, and we have to consider the degree of hypertension. So we can give them analgesia, as well as we can start them on arterial dilators like NTG, nitroprusside, vasodilators like a hydralazine and a labetalol in post-operative period. Coming to hypertensive crisis, there are two kinds. We like hypertensive emergency as well as hypertensive urgency. If the blood pressure is more than 180 by 120 and the patient has a end organ damage, it is defined as hypertensive emergency. The clinical features mainly includes the patient would have a encephalopathy, aortic dissection, there would be acute myocardial ischemia or infarction, intracerebral bleed, unstable angina, or pulmonary edema. And in a hypertensive urgency, the blood pressure would be 180 by 120 millimeters of mercury with no end organ damage. However, the patient may complain of severe headache, shortness of breath, epistaxis, and the patient may be very anxious also. The main goal is we should not reduce the BP abruptly. The initial target would be 10 to 15% of MAP should be reduced in the first hour, and in the next 24 hours it has to be again reduced, like it has to be slowly reduced to avoid any cardiovascular events. The main causes for these hypertensive crises would be acute withdrawal from antihypertensives. There would be any head trauma, pheochromocytoma, or renal artery stenosis, and all those secondary hypertensive causes. And in these patients, we can start with sodium nitroprusside, nitroglycerin, or IV calcium channel blockers like nicardipine, labetalol, esmolol. The sodium nitroprusside is mainly avoided since it can result in tachyphylaxis and may cause in cyanide intoxication. And nitroglycerin is starts acting in 2 to 15 minutes, and we can start it with that. Or else we can start with nicardipine hydrochloride 5 to 15 milligram per hour IV. But it may cause tachycardia like other calcium channel blockers. Thank you, sir.
Very good, excellent. The thing is, the first part of the question, can you read what is the first part of the question?
Physiology of BP regulation, sir.
Physiology of blood pressure regulation. You stopped with short-term regulation with baroreceptors alone. You have not elaborated on the aldosterone angiotensin
Yes, sir.
system.
Oh, sorry, sir. Yes, sir. Shall I tell now, sir?
Yeah, if you have prepared, you have to write that.
Yeah, I have
because
prepared,
that
sir. I
one
just
complete the answer.
Yes, sir. I forgot, sir. Sorry. 1 minute, sir. The short-term regulation is mainly by renin-angiotensin-aldosterone system. So when the juxtaglomerular apparatus senses reduced perfusion pressure in the kidneys, as well as reduced sodium content in the distal convoluted tubule, it stimulates the renin to be released from the afferent arteriole. Renin are stored in the vesicle, and it will be released in the system. This renin is converts an angiotensinogen, which is produced in the liver, to angiotensin 1. This angiotensin 1 is further converted into angiotensin 2 by angiotensin converting enzyme, which is present systemically in the lungs, that is pulmonary endothelium, locally in the renal endothelium also. This angiotensin 2 is a potent vasoconstrictor. It directly acts on the AT1 receptor in the blood vessels, resulting in arterial vasoconstriction. It acts on the hypothalamus to increase the secretion of ADH, antidiuretic hormone. It increases the sympathetic response by increasing the secretion of noradrenaline. It also increases the aldosterone secretion, which again increases the sodium and water consumption, and increases the reabsorption of sodium and water in the proximal convoluted tubule also. So Finally, it increases the circulatory volume and blood perfusion to the kidneys.
That also has to be included in the answer. Then you read. Otherwise, the presentation was excellent.
Thank you.
About it. So I'll just go on to show what important points have to be